In this assignment, you're going to make yourself a reference to use as you work through your exercise testing case studies. This is a reference that's going to be for you, so make sure you put as much into it as you're going to want to work through your case studies. Now, when we analyze exercise testing data, there is a systematic approach you can use. The systematic approach includes starting off by determining the maximal effort of the patient, or what level of effort do you believe that they gave. You find their VO2 max and their VO2 per kilogram, and if it's reduced, then in the next steps you're going to want to find a reason that explains that. Next, you're going to look at the patient's cardiovascular response, followed by the ventilatory response, followed by gas exchange, and lastly, metabolic. Then, once you have all of that data, you're going to correlate it with your clinical picture from the impression of all of your findings. Determining maximal effort can be done through a couple of different ways. The first way, and probably the most commonly used, is by looking at their heart rate. If the patient achieves greater than 85% to 90% of their predicted maximum heart rate, then we know that they have given their full effort. Another method is to look at their minute ventilation at the end of exercise. And in this method, we're looking for them to reach their ventilatory capacity or their ventilatory ceiling. To do this, we can use either the maximum voluntary ventilation or the FEV1. So if we use the maximum voluntary ventilation, then we take the end of exercise minute ventilation, and if it is between 50 to 80% of their MVV, then we know they have reached their ventilatory capacity, or they're close to their ventilatory capacity. Another method then is taking their FEV1 at rest, taking that times 40, and then determining if their end of exercise minute ventilation is 50 to 80% of that. Lastly, we can do absolute values. So the first two ways, using the end exercise minute ventilation and seeing if it's the 50 to 80% of the MVV or the FEV1. When you calculate that out, that actually comes out to a percentage, but we could use an absolute volume. And to do this, we would take the maximum voluntary ventilation at rest and subtract out the minute ventilation max. And if that value is less than 15 liters, then again we say that they have met their ventilatory capacity or are near their ventilatory ceiling. So that means they gave great effort, very good effort. Next, if their SaO2 at end of exercise is less than 80%, we can also look at their metabolic work. If their RER is greater than 1.10, or if their lactate is greater than 7 millimoles per liter, that means or indicates that they have given great effort. As a side note, if you get an RER of less than 1, usually that suggests they did not give good effort or were deconditioned and unable to keep going. And then lastly, the clinical investigator's opinion. Based on what they perceived from the patient, they can also state what type of effort they believe the patient gave. Of course, that's probably the least accurate. Okay, in the last picture I mentioned the max predicted heart rate, so I should mention how we're going to calculate that. To calculate this, you're going to take 220 minus the person's age. So for example, if we have a subject that's 40 years old, we would take 40 from 220, and our answer would be 180 beats per minute is their predicted maximal heart rate. If the subject achieves at least 85% of that, so in this case, if we took 180 times 0.85, our answer would be 153 beats per minute. Then we say this patient is considered to have given maximal effort. A couple other important notes. Because maximal heart rate varies among individuals, some patients may reach or exceed their predicted maximum. Many patients won't achieve 85% of their predicted heart rate. In this case, we will identify that the patient was symptom limited. So they became too short of breath, or they became exhausted, or they had chest pain before they reached 85% of their predicted maximal heart rate. For whatever reason the test is ended, whether it's because they reached a maximum level of something or because they had symptoms or because they said I'm just exhausted, make sure you always note that and take that into consideration as you evaluate your data. So here's an example of how you could set up your reference sheet. By all means, you do not need to use this exactly. You can use any format you like, but here is just an example of how you could. I want to make sure you understand I do not have all the detailed information on this sheet. There are many details left out, which I would hope that you would add to your sheet. So this is not complete by any means. It just kind of gives you an idea of how you could set it up. But notice the very first steps we do is we determine maximal effort, we assess the VO2 max and the VO2 per kilogram. If those are reduced, then we're going to try to find a reason for that from the different assessments down here below. Cardiovascular, a ventilatory problem, a gas exchange problem, or a metabolic problem. So for cardiovascular response, some of the things we're going to consider. Is the ECG acceptable? Well, whoever's running the test, if the test was continued, then it better be acceptable. Was the ECG consistent with the resting ECG? If not, then that tells you something. That tells you that with work, it caused a cardiac change or a cardiac problem. Sorry about that. Next, is there evidence of heart block or ischemia at rest? Again, if there is, the test maybe shouldn't be ran. If the heart rate reached 85% or more of its predicted, did the rhythm change with exercise? Obviously the rate's going to change, but did the rhythm change? And hopefully you all know PVC is the most common arrhythmia that occurs with exercise in patients who have cardiovascular problems. What was the blood pressure at rest? Was it normal? Did the systolic blood pressure increase with exercise but not exceed 250? Remember, if it goes up to 250, then that is exercise-induced hypertension. Was the diastolic blood pressure constant, or did it only decrease slightly? Okay, so you're going to use those criteria to evaluate the cardiovascular response to exercise. And did that play a component in the limitation of the patient? So is there a cardiovascular problem causing the dyspnea during exercise for this patient? Okay, next we're going to look at our ventilatory response. First and foremost, was the appropriate test used for the patient's condition? Obviously, if you have a COPD on 5 liters of oxygen, putting them on a treadmill with a ramp protocol is probably a poor choice. So you want to consider the test chosen. Next, was there resting minute ventilation between 5 liters per minute? Was their minute ventilation increased with workload? Remember, it should increase linearly, actually. Was their minute ventilation max less than 70% of their MVV? Did their tidal volume increase to 50% of their resting vital capacity? Okay. Was there flow limitation evidence? Remember, flow limitation is obstruction of the airway. So if that's present, then that can be causing the dyspnea. Was the tidal volume consistent with a breathing strategy? Your book talks about a breathing different breathing strategies and how normally first your tidal volume increases and then your respiratory rate increases after that. Patients with lung disease, either their tidal volume won't change and their respiratory rate will change, or their tidal volume will change and the respiratory rate won't change very much. So there's different breathing strategies, and is that consistent with the other data? And then lastly, why did the patient stop? Were they just so short of breath they couldn't continue? Were they exhausted? And so forth. Next, you're going to evaluate your gas exchange. The first question is, did you obtain the sample correctly? Was a blood gas taken at each level or only at the peak exercise level? Did the PaO2 decrease with an increasing workload? If PaO2 decreases, did it go lower than 55 mmHg? Did the PaCO2 remain constant or only decrease slightly? Did the pH decrease to 7.2 or lower? Was the VD-VT ratio normal at rest? And then lastly, did the ABG correlate with the cardio and vent variables which we already observed? Next, we look at the metabolic. The first step is to make sure all the data and calibrations were performed correctly. Was the appropriate reference selected based on the patient's height, age, gender, and race? Was VO2 max achieved? Was VO2 max less than 80% of its predicted? Was the anaerobic threshold reached? What VO2 max was the anaerobic threshold reached? What could explain a reduced VO2 max? And why did the patient stop the test, or why did they ask to stop the test? So again, these are some of the highlights of each thing that you need to evaluate when you look at the data, but it's by no means every single detail. To get those details, I have provided for you where you can find them. And these are in the interpretive strategies boxes. For your cardiovascular assessment, it's going to be interpretive strategy 7.1, and you can find it on page 202 or 203. On my screen, it comes up kind of right in the middle. For your ventilatory interpretive strategies, you're going to look at box 7.2 interpretive strategy, page 227. For your gas exchange, you're going to use interpretive strategy 7.4 on page 220. And then for the metabolic, you're going to use interpretive strategies box 7.3 on page 216. So notice these do not go in order of how you would evaluate them. Okay, one more thing I want to go over with you is I find this to be a very nice layout of how to use some of your information based on the type of condition that is interfering with their exercise capacity. So if their dyspnea is caused by a cardiac problem during exercise, these are the different items you would evaluate. For example, your VO2 max would be less than 80% of predicted. Your minute ventilation max might be less than 70% of their maximum voluntary ventilation. Their anaerobic threshold will be achieved at a low VO2. Their heart rate will be greater than their 85% of predicted maximum. That's because their heart rate will increase, but their stroke volume won't be able to, so it'll be highly dependent on the heart rate, so the heart rate will be higher than expected. Was there ischemia on the EKG or any ST changes, any arrhythmia or chest pain? And then their SaO2 would be greater than 90%. So you see all the criteria that you can expect for a cardiac limited patient, a ventilatory limited patient. If the patient's just deconditioned, they're just out of shape, or if your patient gave poor effort. Again, these do not include all of the details, but these are a very good table that I would include in your reference sheet. I hope this is helpful for you.